Okay.
Yeah, beautiful. Now this case.
Case number 5.
Yeah. This case actually, let's go. We started with the patient, 62-year-old female who had chest pain and dyspnea. As you see, that this time we have clearly avoided the Canadian class as per guidelines of the AUK. Remember, AUK also, they had taken away Canadian class completely because majority of these patients, they don't fall into Canadian class because they don't have chest pain. They have dyspnea, their shortness of breath, their limitation, their activity. So clearly, based on that, I think overall, the patient is symptomatic or ischemic. That is where the whole case of the ischemic heart disease is being counted. So this patient particularly had risk factors of diabetes, hypertension, high lipid, positive stress test, and is in good medical therapy. Cath was done, 3-vessel disease, and had a syntax score of 24. And patient had discussion with the surgeons, although you can make a point that maybe particularly with the 3-vessel disease, diabetic should refer patient for surgery. Yeah, we do refer, but after discussion, half of them, we have our own data that after discussion with the surgeon, the patient comes back to the interventionalist because of this heart team and patient preferred surgery, or sometimes surgeon refuses the patient having a cabbage. So this patient actually had a rota stent of the OM, didn't look that calcified, but see the RC, the LV is good. RC has a diffuse disease with a total PDA, which will be this is that OM, which was very tough to crack. After balloon dilatation didn't open, then they did a rotablation and then put a stent which Promus Premier 2.524 came out very good. And today is here for LAD diagonal bifurcation with a moderate calcium. There is a disease at the ostium of the diagonal, so you can call it a 111. Although the diagonal is about 2.25 millimeter vessel, there is first diagonal, which is diffusely diseased, moderate size. There is no disease of the LAD at that place. So we felt that we just concentrate on the mid LAD, although it looks like only mild little flakes, but we know, particularly this particular case, only what little flakes into the circumflex. That had to do a rotablation because lesion did not crack. So we said, well, we do IVUS and try to learn a little bit what is the lesion morphology. So we did the IVUS here. They're going to change to IVUS, and you can see that yes, the calcific we play. So one area of the calcium was 1 quadrant, and the second area is 2.5 quadrant type of calcium, but not a circular. The cases which we have showed today, the circular calcium, though this one is still was a 2 quadrant calcium, and as you know, it takes not much from us threshold point of view because of the history, what happened in this particular case in the circumflex, we felt that let's just quickly do a rotablation. Then that is what we did.
So before you go, I know you're choosing. So again, it's another bifurcation calcific lesion. But the question of whether or not we need rotational atherectomy or what about orbital atherectomy in a case like this is something to be talked about. We have a great panel. New to the panel is John Fox, Cindy Grimes, Stefan Windecker. Who else am I missing?
While you continue, because I'll tell you reason is because we have beautiful case, one more case ready. But yes, these are a very good point. Whether you use a rotational orbital, I think is any one is a dealer's choice in this kind of case. Few cases which we discussed earlier where orbit versus rotational is preferred. But here, yes, if need to be, you can use any. And this is done by Joe, and we are dilated with a balloon. And we felt that it's a small vessel, side branch, 2.25, just do a flextome, cutting balloon, and we had done 2.25, the multiple dilatation. And this is where we are. So ostium looking perfect, LAD here. We decided to begin with in this case that we are going to do a 1 stent approach in the LAD, and we are ready now with the 3028 synergy. While you're having a discussion, we are just going it because we will want to finish this case quickly and then go to the next one, which they are ready in next few minutes.
I think this case does generate some nice discussion. Any comments from anyone on the panel? Cindy, would you proceed in this direction? What did you think about the cutting balloon and no stent, in a single stent by putting a cutting balloon on the side branch?
Well, I think that's a great idea to do a single stent strategy. And in my personal experience, we have a lot of recoil from osteal lesions. And so I think using a cutting balloon or a scoring balloon is a very reasonable thing to do. And plus the angle of takeoff of that diag is quite shallow, right? So if you were going to stent that, it's definitely going to impede flow in the LAD. So it's going to end up being a crush or some other complex technique. I don't know about the rotoblader. I think once you do the IVUS and you don't see that huge arc of superficial calcium, I'm not sure whether it's absolutely necessary, but they certainly got a great result.
Any other comments, Stefan?
Roxana, I think the operators have the privilege from the previous experience, and I think this is very important. So if they encounter the difficulties in the marginal branch, I also would have a very low threshold to have a very good lesion preparation in the LAD. Is it absolutely necessary? Probably not. But I think as you already have seen the result after the lesion preparation, it's excellent. So I think it was a good strategy.
It was a good, yeah, I think that was Dr. Sharma's sort of low threshold.
And now look at this even. After that, this is a 3O. The mid portion has still not dilated. Do you have a winging of the stent at the corners? Now we are going to take the wire out of the diagonal, rewire it. Pull back more. Yeah.
I think one thing you can say is that the disease burden is heavy and that it is diabetes. And one of the other discussion points you can have is you do part of this, but does a hybrid come in? Can you put a lima to the LAD and walk away with, you know,
We can leave it
probably the benefit that diabetics get in a 62-year-old?
So it's a really, really good question. Dr. Patel? Oh, sorry. Dr. Botello, what do you think about that idea of a hybrid?
That's a
Robert.
good idea, but I would invoke the functional syntax also to make decisions in such a complex case. That's a good idea. And I'd like to say that before the case, I would do completely different. I would not use rotoblader, and I was concerned about the diagonal osteum. And Dr. Sharma told us did completely different from what I would do. That's amazing about the live case.
Yeah, right. And we want to see some radial. We keep seeing femoral cases, Dr. Sharma. What's happening over there?
No, radials are coming. They're coming also. Yeah.
Dr. DiMarcina.
Yeah, the other thing is that, I mean, the branch isn't huge, the diagonal isn't huge, but it does have a beautiful angle for the Triton stent. So this is actually also an attractive. Normally, I would be going exactly like Dr. Sharma's doing, except the rotoblader plus minus, but the... now with the Triton stent, with this type of angle, I'm more
How's that
leaning
better
towards
than
that.
balloon?
With
How's
a
that
small
better
vessel,
than
because
ballooning
that's
in
a
a
small
small
vessel.
vessel when putting in a bare, because it's a bare stent, if, you know, the current generation of the Triton? How is that?
Well, first of all, you get beautiful expansion at the actual ostium, and then if restenosis becomes a problem, you can always. It's much easier to treat stent restenosis than a jailed side branch with conventional method.
So it's like a culotte, right? I mean, I think it's important. And we'll talk about that a little bit later. Any other comments?
Yeah, the other technique, you know, I don't rotoblate. I would not rotoblate this, but what I tend to do is pre-dilate and try to get a sense of what the osteum's going to do before I go in and intervene. And sometimes I just try to get away with putting in the stent.
And as you see that the osteal diagonal has been reasonable, so what I'll do is, for the sake of time, this probably will qualify one of our less complex case. So we are ready, Anu is ready in other room, but this is a simple, straightforward, because what I wanted to emphasize only one point, and we don't have the data to support clearly, that the side branch using the flextome or angiosculpt means atherotomy, to avoid that recoil which is seen many times when you put a stent across, is a trouble, and therefore I preferably use the tight lesion of the side branch, then use the usually it's the flextome, and if not disease, I just leave the wire. So with that note, I think it's a reasonable case. We are quickly done with this, and
We go to case 6, yeah?
Yep, and they are ready for case number 6.
All right, thank you. Thank you so much. Excellent. Case number 6, Dr. Kinney, here you are. With Dr. Baber, I see. Yes, great.
Welcome to the panelists, and I just have to say the 20th year of our CCC Live Symposium is something really special event. Just to say, in the interventional cardiology, you see women moving up the field. So you have a woman operator, you have a woman moderator, and you have two strong internationally famous women, which is Cindy Grimes has just joined the panel, as well as Marie-Claude Modis, who is in the panel. So I don't think you will have any other meeting with that kind of female faculty representing.
That's right. How do you like that?
meetings.
How do you like them apples?
We want applause.
All right. Give us case number 6.
Yeah, this is, you see QP, 70-year-old female, who actually again presented last week to the outside hospital with unstable angina. Troponin was negative. Risk factor-wise, she does have atrial fibrillation, diabetes, and most of the ischemia was on the lateral wall. So she was on good medical therapy. She did have a cath at outside hospital, which showed she had distal left main disease, proximal LAD about moderate, but most important was a significant circumflex disease with a syntax of 26. In the outside hospital, heart team discussion was done. She did not want surgery, so patient was referred here to have the PCI of the left main. So here we are. EF, near normal LV function, right coronary artery, prior multiple PCIs, but all the stents are patent. And this is the left main moderate, which I think here you can see it about 60% or so. But most important in the cranial view, this is what you're going to, you're appreciating the significant osteal circumflex disease, and also the amount of calcium that you will see in this
That
case.
gives me some pain looking at that view over there.
This is the amount of calcium.
Lots of calcium.
Yeah.
Wow. Marie-Claude, what do you think? Impressive, no?
That it's a very complex case, as usual. Even entering in the circ will not be easy.
We agree.
It's a very nice educative case, and I'm looking forward on what they will do.
Yeah. So I see already you put a balloon pump in. Tell us your
So what
reasoning.
actually happened is when we had seen the angiogram from the outside hospital, it was a different looking circ. But I think in the last couple of days when we saw this angiogram, she has distal left main and a calcific almost total circumflex, and that's when we thought this is a kind of angulated circumflex. If you have a difficulty in wiring, especially if you have a vessel closure when you're wiring, that she will need balloon pump assistance. So we thought while we are waiting that we will have a prophylactic balloon pump.
So in the last case, before you go, in the last case, John Fox said, how about doing some hybrid revascularization? So if your patient is refusing bypass, how about, I know we're going to undertake the hybrid protocol here at Mount Sinai, which is a protocol that's an NIH approved protocol with John Pluskis and Anatine Jellins. But what do you think? Is this a good patient for that? Is that something that you might even consider doing a Lima to this LAD or a hybrid operation, or you think you're going to be able to take care of all of this in one go around of a PCI?
I think when you are doing a hybrid case, it has to be a complex LAD rather than a complex circumflex.
Excellent. Yeah. That's a good
So
point.
this will not be an ideal case for that procedure. Usually they prefer just a Lima to LAD, and the rest of the vessels we will do the PCI work. So here, as you see, the complexity is all circumflex. That worse comes to worse, you can stent across the entire circumflex and leave the LAD alone and come out.
Okay.
But I think the important point here for when you're starting this case, that other than that if the circumflex is likely to close, you need to think of how are you going to wire this angulated circumflex. So just to give the points how that we would handle it here is that you go with any kind of over the wire, whether it is a fine cross, micro 14, any kind of the catheter that is available out there, or even a over the wire balloon. And then use your first wire should be polymer coated wire which should be fielder. Even if people want to use a fielder XT, it's not a wrong choice in this case. And be ready with your CTO wires, that if you're not able to cross this with your fielder, that you will have your specialty wires ready, which should, people may like Pilot, but could be Gaia or Miracle should be ready with you to get the circumflex wired.
Okay, so can we watch you wire this?
Yeah, so this is our, if you see that, I just went with the fine cross I have, and with the fielder wire, able to get into the circ.
Nice.
So the amount of calcium there, the fielder was able to negotiate.
Did it really take that short of a time?
Yeah, it was 2 seconds. Everybody's here watching me. And then the next point is that, yes, amount of calcium is there, that we plan to do rotational atherectomy. What is the burr that you want to select? So one of the tests that we normally do is you have a fine cross, the fine cross the lesion. In that case, I think 1/5 burr would be an ideal case. But more important here, we know we do not have the rotawire. You see that? Because of the calcium and tortuosity of the circumflex, we were not able to get the rotawire all the way distally. In that case, this is the ideal case where you want to have a rota extra support wire rather than using a rota floppy wire. So we do have a rota extra support wire there and a 1/5 burr ready to go in the left main.
All right.
All right. So let's go do this, and then you'll tell us, you'll guide us when you want to go to the next case, Dr. Sharma.
Yeah, no,
I'm waiting for you.
This is the case, as you saw. It came from other place actually. They wanted to do surgery, which could be fine. But again, many times these patients are the one which make a final decision what to do. And with that note, patient is here with a 1.5 burr, which we are starting now. Although we don't have much purchase, so I have to be a little slow. Yeah. We put a balloon pump, although EF is near normal. She had a just very small non-STEMI troponin positive that we thought that if circ closes, will give rise to a problem acutely.
Yeah. So
in the RCA picture, you could see the collateral to the circumflex.
yeah, we saw that as well. Any comments from the panelists at all? Yes, Dr. LaSala.
Yeah, I think the point that Dr. Keeney mentions is very important to reemphasize, and that is on these subtotal, heavily calcified lesions, that you have to be prepared to do it as a CTO. Now, they were very fortunate and skilled, obviously, to get down with a relatively, a workhorse type of wire. But you have to not only have the wire backup, but I often use more of a more durable microcatheter, like a Turnpike LP I've gone to more frequently, to spin through there and get through these high-grade stenoses, because without getting it through, of course, I can't get a rotoblader wire in. And once I've done that, I don't usually have to use a 125 burr too, because of the diameter of that catheter would mitigate against using something smaller.
We did.
Yeah, so it's so tortuous that sometimes you do have to spin. Any of the, a lot of the CTO catheters, I notice that they have to spin, especially if they're subtotally occluded and calcified. I'd be a little concerned about the second lesion. It's so,
yeah, it did.
Its proximity to that sharp bend. If the rotoblader jumps through there, I'm afraid it would dissect or perforate. So, taking your time, going slowly would be essential.
Dissect or perforate or even stall. Getting, if you hit it just right, get halfway through there and suddenly it decelerates, now you're stuck because you can't get it spun up again.
Okay. You saw it very controlled movement, no jumping. It's a very tough angulated vessel. Now question still comes that what we should do for the main LAD, left main to LAD, which is also moderately calcified. I'm sure we do the IVUS will be a big, by definition.
You want to use this bar? You see how the circ behaves?
Yeah. No, but if we need to do, let's see. Because if we need to dilate the ostium of the circ a little bit.
Yeah, would you dilate the ostium of the circ before you start rotational atherectomy in the LAD?
So a little balloon there, and then use maybe 2 burr from left main to the LAD, proximal LAD.
I think if you dilate, we may lose the circ.
Could you show the other view of the circumflex, because that did show that proximal lesion much better.
Yeah.
Which view? The cranial? You want the cranial
Yeah,
view?
it was
Yes,
the
the
cranial
cranial
view,
view.
the aleocranial, I think.
1744. That's where it showed it.
It looks like you got nicely through the second lesion for
Yes.
sure.
Yeah. No,
It's
so
the
both
ostium.
lesions are taken care, yeah, of the circumflex. But
Yes.
now the LAD, see that it's a tram track, very calcific left main to LAD. It's the same. You can do IVUS you want to the anytime IVUS OCT, but this was a clear-cut case of the severe calcium of the distal left main to the proximal LAD.
I think
Yeah,
angioscope
the
might take care
osteum
of
is
it, no?
much better. Huh?
Yeah, I might do an IFR of the LAD. It doesn't look, I mean, it's hard to tell because there's a series of lesions, but even after the second diag,
we
there's a
won't go
lesion.
further. No, we are just talking about at the level of the left main. Yeah, we are not going to go further down into after the diagonals, and so we just concentrate on the at that level.
Dr. Sharma?
Yeah.
Are you concerned about now, if you decide, as you suggested, to dilate the circumflex and then rotablate the LAD, are you concerned about losing the access to the circumflex?
Exactly
that's
what
what
I just
Dr.
mentioned.
Kinney was
Nina,
saying.
That the significant disease we went in the diag.
Yeah.
That significant
That's
disease.
fine. Leave it.
Can I have the fluoro?
Yeah,
Can I have
good.
it?
Good. Yeah.
So just to,
Yeah. No,
sometimes...
but you're right. That is always the question, the concern comes in these complex cases, that even if you've done the rota, but it's a bifurcation, other vessel is also calcific. But I would say that if you have done the good balloon dilatation, and there is not much terms of, it may have little dissection anyway, but not any significant dissection, it will be, no.
Fielder for the
Yeah, so that you could just take the wire out, put a wire into the main vessel and then do the atherectomy. So I think in this particular case, because of complexity and knowing that the tight lesion was the tightest lesion was the left main to circumflex, which has been taken care. So nothing wrong in that particular case would be that if you want to just do a balloon or let's say flextome 3.5 and see if you have expansion at the level of the distal left main to the LAD, maybe avoid the rotablation of the LAD. And if you cannot expand it, then I would say clearly open up the ostial circ anyway. And you want to go to other view?
No.
Okay, good. Yeah.
But just to think of it a different way for the hybrid, sometimes you can create the stenosis in the LAD. So if you come in here and just treat this as more simple circ disease,
I'm gonna take out the
stenting
rotavirus.
from the LAD into the circ, you'll shift black over, and then to come back, and you can do a robotic
Can I
lima.
have the fluoro, please? Yes,
Yeah, but I mean, I think, at this point, when you're seeing this, you probably want to proceed, but it's a very, very good point.
Yep.
Any other
Good.
comments?
Okay. Now you
Eduardo?
give the balloons.
Yeah, let's do the ostial circ first, because that is we need to do that even if we plan to do a rotablation of the LAD. So this is the first thing we are doing. The fielder wire is back.
We have the fielder wire to the circumflex. We took the rotational atherectomy wire out, and then we have a run through in the LAD.
Ready here? No. Yeah.
Okay.
IVUS we have ready also. Anytime we feel like, and of course we'll do, that we are ready to do the IVUS run.
So I'm seeing again IVUS. When would you ever use OCT for anything in this area? Because I keep hearing everyone wants to use OCT now to,
but
all the data is for IVUS.
No,
but
let's ask the question to the panel.
Yeah,
Yeah.
panel. This is what I'm asking. Can the panel tell me when do you ever use OCT at all for? Stefan, do you use OCT? What do you think? What do you think we learn more with OCT or?
Well, I think here in this case, this is not a case where you like to use OCT because you already couldn't pass it through the lesion, for the pre-lesion assessment. But I think where OCT is excellent is in any kind of stent failure you may have. I think it's also excellent if you want to look at the stent apposition and so on. But here, the pre-lesion assessment of the circ would be not possible.
Carlo DeMario gave us a beautiful talk on IFR. Do you ever use that? Would you ever use that in this LAD, Dr. Sharma? Dr. Sharma.
Yeah, Dr.
IFR.
Yeah, we could use IFR for the.
Would you
for
the LAD?
But
Yes,
after the
IFR or yeah, but you have to open the left main first.
Yep. So there are a lot of disease in the LAD, but so I think IFR after opening that will be okay. Now question is always the OCT. Remember in my the top 10 I kept OCT because we have two major trials. You need to advance that wire a little more. Yeah, the two major trials with the Illumin 3. Again, comparing all three, there is no convincing evidence that clearly I know that Illumin 4 is already being planned with the OCT and the angiographic guidance in the complex cases. But clearly we saw, and the same in the doctor's trial using OCT, you get a little better lumen or better FFR in the group, but still, does it translate, just like which is done with the IFR and FFR, does it translate to the real good outcome? So that is biggest issue remain. So OCT pictures are beautiful. For the, as just send a statement made by I think Stephen that good for the understanding the mechanism of the stent failure, but really as a day-to-day routine of your practice, how much it will help. I still need to be convinced. Not saying that it works or does not work. I just need to be convinced by any of the data.
So tell us what you got there now.
Now this is a 3-5 angiosculpt balloon. We are
At
going
20
up to 20 atmospheres.
And seems to be okay.
Yeah, it looks like you dilated it, and
down.
with all the tram track,
Yes.
you were still able to get it.
So we do.
So maybe you don't need
pressure.
rotoblader in every case, Dr. Sharma.
No, but this circumflex was so difficult.
No,
Sir, would have
circumflex,
been
no
done.
question, but maybe in the LAD, I like the idea that
Ostium, no, pull back.
I think the historical data with IVUS and arcs of calcium is what everybody really reaches for when you're choosing to decide to do rotoblader too.
Because same thing, I can tell you that you do OCT and there is no clear definition with the OCT what is severe calcium. We know at least the arc of calcium and the IVUS tells you moderate calcium, severe calcium, whether 90 degree, 180 or more, and so it definitely tells the depth of the calcium, which IVUS doesn't tell. So I think it's a lot of issues. But again,
but there is a we can use a quadrant, whether you have 1 quadrant, 2 quadrant, 3 quadrant of calcium, the same thing, even with the OCT definition wise for a calcific lesion.
So let me understand your strategy here better.
Yep.
You're going to go 2 stents here, it looks
Yes.
to me.
Yep.
We have a lesion distal to the left main in the circ that
Yep.
really definitely needs to be treated. You treat that
we'll
first,
use the
right,
long
or
stent
not?
in the circ.
Can you show us?
Yeah, we'll take this picture.
The
and then
question
we go
with the
to
long
that.
stent, we just want to make sure that it will make a turn.
Yeah,
We do
that's
have
what.
a 24 millimeter stent and we have a 28 millimeter stent.
Yeah.
We want
go
to-
to caudal view. Make
Yeah.
sure the wire is distal,
More wire
does not go
distal, yeah,
distal.
if you can.
or
It's
as
not
long as it has
distal.
crossed that lesion. Are we okay there?
No. It crossed a lesion.
Yeah.
May not the stent, may not go. The long one.
Tell them that there's room.
Yeah, it's
Okay.
so tortuous that the wire doesn't want to
Guide
advance.
wiring, everything. Yeah.
What's happening with that wire?
Yeah,
Maybe you need
that
a new
circ
one.
wire is misbehaving. Okay,
Yeah.
this is the view where we have to decide the length of the stents here.
You want
Right.
to put another different wire?
No, I think we'll be
Actually,
okay.
I've been very much impressed with the Boston Scientific Marvel wire also
Go.
in these situations. You can put a Marvel side by side and then take this wire out.
So tell us about that wire, Dr. Sharma.
Yeah.
Which wire you're talking about? The Boston Scientific?
Yeah.
Which wire?
It's all the new class of wires. Many of them, they come and go. Looks like this may stay.
You think?
And, yeah, it's a more kind of hydrophilic competitor to our the fielder wire. But I saw it. It keeps the shape, retention of the tip, and you can use it in multiple areas. So now you'll see here, this wire should go very nicely, and then it gives a moderate support. One of the big issue remains with the fielder. It's a great fielder will go into various of this tortuosity. But once you talk about the support of the fielder, that's where I would say gets a minus point.
Okay. Well, let's see how this behaves. Dr. Matthew, any
Yeah, just
Matthew,
to, I
Samuel?
want to make sure
Dr.
again
Samuel?
the point of the OCT that all the cases which we did, 90+% cases of the absorbed, we did with the OCT. So where we know that is the edge dissection, stent expansion, all those things are very important. That definitely the OCT is your best bet. Beyond the data we get from IVUS, and now actually Samuel, Dr. Matthew can answer the question. Yeah. If not, you just
I mean, as far as the OCTs are concerned in left main, I have no hesitation in using it at all, because you get as much information as the IVUS is giving, even if it is calcified. It's mainly, as Kinney said, it's the arc what we are looking at. That information is good enough to decide.
Done?
And even in 4 or 5 millimeter arteries, visibility is quite good.
How can you
Proximal
at least the other one is making a turn there.
quality
Get us
of
a
the
stent.
picture is excellent.
Okay, good.
Yeah. It looks like that new wire didn't do much better.
Yeah.
I
All right,
think,
we'll try again.
I
Yeah.
Okay.
think Sharma, Kinney didn't like the wire.
I know. That's it. The next one, I'll do it.
When you don't hear any comments from me,
Yeah.
No, you didn't like it.
Yeah, that's it.
give me.
So now you're going to use are you going to use the angioscope in the circ as well before
No, I think it opened up
stenting,
well.
or you think
We
it's
opened up
open?
well.
I think that opened nicely.
So we have a 28 stent. We have a 275/28 going to the circ.
Is the Promus?
Yes.
Okay.
275. You think
And
you're
then we have a
underestimating the
30.
size of that circ?
30, what you want, 20, 16?
20.
20. 35, 35, sorry.
35. 35, 16.
Okay.
35, 16.
I know, but
Yeah, that's
this
good.
one I was a little concerned about 28.
Yeah.
See that?
Yep.
So I wanted a
Yeah,
24.
yeah, let's get 24. Take it out.
Yeah.
Yeah. Yeah, 24.
I said 24.
So 24, but
Yeah, 28 was a little
275.
too
Are
big.
you being too cheap for the vessel? Maybe it's a 3-0.
No, it's sticking too much in the left main.
Okay.
Yeah. Yeah, because key is that it will be a big crush.
Yeah. You don't want that. You want a mini crush, right? You want it as low as possible. Any comments?
Yeah, I'm not opposed to the 275. I think I like to stent to the distal vessel, and you can always post-dilate.
Post-dilate it
Yeah.
higher up.
I've
yeah.
seen too many
You're good.
vessel dissections and ruptures
me
when you...
Especially in
Single
that
wire.
distal area where she doesn't have the wire in the
recross?
best possible place. You're right. You're absolutely right.
Sharma,
Yes.
I mean, we all know that the highest restenosis rate is when it involves the circosteum.
Yeah.
Do you have any trick to reduce the restenosis?
I think it's the same is that we need to have a little more aggressive debulking. You have opened it nicely. You're right. It always has been the Achilles heel in these bifurcation cases.
Some dye here, no. I think it's this also too long, SS, very bad.
Yeah.
No?
Does it not want to go down distally because you just don't have good wire support down? Here, there you go.
No, that's okay. That's all right. Yeah.
You want to
Good.
leave it
Use
like
the other
that?
one. Yeah. That's fine.
It's too much crush, no?
Yeah.
Okay. Get us a 3, 5, 16 now.
Yep.
Dr. Matthews, you are asking something.
Yeah.
to
Question,
reduce
what
the
you do a
restenosis of the
circumflex
circ?
Circumflex ostium stays same even after you have done the rotational atherectomy using the cutting balloon, then use a high pressure. So clearly, the preparation of the ostial circ is the most important in these cases. And also when we are doing a mini crush technique, that we have gone to the distal strut, so it has been opened nicely. So all those factors.
Is there any difference between circ to left main or LAT to left main?
Yeah, I think
Depending on which vessel is larger. Right?
fluoro. Yeah.
Good,
Ready?
Sidney?
You want to go? Okay, good.
So not to, let's show us this, and then I'll tell you about
I'm
our
going to
timing here.
Okay.
This is a circ.
Circ. Okay. I'm deploying the circ now. We are going to take the circ wire out after the deployment.
And you'll need a new wire. This wire has done its job.
16.
Down. Go up again.
Is there any data that twice expanding the stent makes any difference?
Well, yeah, that's a good point. I can tell you that we adopted that policy from Washington Hospital Center when I went many years ago. It was basically, idea was that your first inflation, your stent is expanding against the resistance of the plaque. So second inflation, ideally, I mean theoretically, I don't know whether there is clear-cut data of the IVUS, but it makes sense that you'll have now the better, more circular expansion. Now, is that true? I think it's true. It's become a habit. And we are not corroborated or confirmed or disproved that hypothesis by doing the IVUS after single inflation versus two inflation.
Yeah.
I think that will be a small good project for the fellows.
So, Dr. Sharma, I'm reminding you we have 12 minutes and
Yep.
still haven't started your case number 7. I
Yeah,
know
yeah.
you're miraculous, but I want to make sure we
Yes.
make it to lunch on
Yep, yep.
time. So,
Yes. So
Done.
5 minutes less.
let's
He said,
see this and then-
we'll give you 105. So 105, so lunch instead of 45 minutes, 40 minutes, because we have a lot of good food at the boat. Indian, Italian, American, you talk about
Okay,
a lot of good
okay.
food. So little
All
light
right.
lunch, 40 minutes. I need only 5 minutes from you.
all right. Well,
Okay, ready?
show us what you have. Nice.
Good. So now we have to just recross
Arthur,
quickly.
recross
Very
and-
nice
So
already,
recross,
yeah.
kiss.
But recross first. The people want to see the recrossing,
Okay.
and then I'll go to other side.
You
Yeah.
go to the other side, Dr. Sharma, so you can
No,
get
no, we
started
are gonna-
there.
He
Yeah,
wants
as soon as you recross,
recrossing,
yeah. And then I go
and
there,
then
yeah.
when you are doing kissing balloon,
No,
you are
not
on the
kissing,
other
just
side.
recrossing.
Yeah.
Just
No,
recross.
Just recross
show you
and go to
how
the other
recross.
side.
The
Yeah.
recross
Excellent.
technique would be the same. We'll use a new fielder wire because of my initial fielder wire that we used. The tip is all gone. Now we go with the new fielder wire. And if we have any difficulty, we'll have to do the pot.
You may have a distal dissection there in the circ, right after the stent.
No, it looks okay. A little botched up.
I think it looks fine. I think
Yeah.
there is some disease. There's disease everywhere. But let's see how
That's
it
how
goes.
calcific complex vessels will look. Oh.
You used to do a lot of kissing stents in the left main. You're not doing that anymore?
Not with the, older generation, which used to be Cypher, Taxus, thicker strut stent, that was very easy. With the this newer generation stent, I think SKS would be much harder. So what I did, I came back, I was able to recross it. Yeah. Now here we may have trouble compared to the first left main where I showed that we'll go with the NC balloon. I'm sure I'll have a trouble going directly with the NC balloon to the circ. So we will go with the 2O. So we'll go with the 2O. Yeah.
But you
compliant
will
balloon.
image this. Will you image this stent in the circ at the end just to be sure that
12.
John thinks maybe there's a little disruption?
Just go back to your previous view without the wire.
You were talking about using the first generation stents, kissing stents, and newer generation do
Look at
not
the outer
stand
portion of
as
that
good.
turn there.
Why wouldn't it work as good as the older generation stent?
No, we are talking about SKS technique. They
What?
were asking, do you do SKS? And I know earlier
Why
they
not,
showed
why
this
not with the
technique.
newer stents?
There's thin strut. If they at all they come back, rewiring and doing PCI through the barrel is way much harder because you can go through the carina in and out with the wires.
So that doesn't look like a cap then there to you.
Yeah, I mean,
It's not acutely. Acutely looks good, but when they come back, if at all they come back, then we really have hard time getting through the carina. So now you see the 2O has gone in easily. See that? So we will dilate here, make some room, and then no, give me the LED balloon.
so this is a 2O
2O,
non-compliant.
2O12.
Just to open the strut.
Start, and then I'll go with
Marie
the
Claude, you have a comment on that teaching point here for our audience?
No. I think it's important because they crush, so there is three layers there. So it's just that a bigger balloon non-compliant might not cross, and I think it's they are on the safe side doing that.
Yeah. Cindy?
So I'm a little worried about crushing the circ stent because there's so much atheroma at the ostium, and so I might have crushed the LAD stent. Actually, I wonder what the rest of the panel thinks of that.
Yeah, I
No,
would agree.
That's a good point.
Plus, recrossing into the LED is going to be a lot easier than recrossing into the circ.
You have the circ stent, what's the 3O balloon? Not yet, don't do it. But I have to get NC
I
balloon.
think I agree with both of those comments. Sometimes I would even come across into the circumflex and then tee it, because I don't think you'd lose the LAD, and it'd be probably an easy T stent to do. The
3O high
beauty of
pressure
this
balloon.
is
3O
that
12
all the
high pressure
vessels are
balloon.
big.
They're good. Go. Go to the other room. Down.
So
Marie-Claude,
Anu,
you're the-
because we need to get some lunch at some point.
Go.
Tell us what what exactly you're going to do until the end of the procedure. Tell us.
So what I did is I kept the inflated deflated balloon in the LAD, went with the 2O, created a channel for my NC balloon. So we have a 3.5 high pressure balloon in the LAD. Now I'm going with the 3O high pressure in the circ, and we'll do the final kissing balloon.
And you will image the both
Yeah, from the
limbs.
left main to LAD.
Okay. All right. So if you don't mind, we're going to go to Dr. Sharma.
Yes.
Thank you. Excellent. Hello, Dr. Sharma, case number 7.
Yes. All right.
I hope this one is radial because I see Nitin.
Yeah, actually the radial is included here. So that even the radial, but it has to be femoral again.
Okay.
But I know that the time issue, and knowing that we always can use the our associate, the side work. So this is a little difficult situation. What do you want to do? The rotablation?
Yeah, I think more.
So you start doing it. Come back here. Do your things again. Yeah. Yep. So now basically very quickly, this is a 77-year-old patient who had a bypass surgery, has COPD, and so had a PCI of the right coronary artery, and then had a left main to the circumflex, very severe ISR, which will be actually for maybe the next symposium. Lima to LAD is good, and he has a very occluded circumflex, as you can see here.
Can you show us the? Here we go.
We have the picture.
The RCA,
No, we don't have the JL. So
we see a lot of stents.
Yeah, it's a
stents.
It's a native left main to the circumflex is totally occluded. There are multiple stents, but the culprit is here, and that is the right coronary where the stent actually hanging outside. Very difficult, very calcific. Then the RCA into mid to distal segment. You can see there at the corner. We very difficult to engage. So this guide was
it's an IM guide, yeah.
internal memory guide. We were able to wire barely across the lesion. Nitin was able to do, and then try to advance the fine cross. And basically the fine cross won't even go because wire could not go any further because of the support.
So before you tell us you're going to do rotational atherectomy here, I want to hear what other people would do in a case like
calcium, this. No, this calcium, we thought that maybe it could be because of initially being a stent. So let's try the orbital atherectomy. So this case was planned for the orbital atherectomy for this calcific angulated, and this actually from the very prominent institution in New York City was declined. So they said, this is a very tough case, cannot be done. I said that definition belongs the case for our June 15th symposium. So here, what Nitin was able to wire it, and you can see that just barely. We tried to advance, and we saw it outside. It's a 6 French guide liner, which was advanced. And the orbital burr, I asked him because we know the publication in the JACC intervention that rotablation you need a 7 French guide liner. This is the 6 French guide liner. So can you advance the orbital burr, OA burr through it? And apparently they could see it outside, in the vitro without any problem. But inside you can see here that we try to go through advance. The wire is still okay side. That we try to advance. Everything started coming down. So that's where we are now to the square one, or you can say that time 0 what we started a few hours ago, that we have to go back through this whole process once again. And I probably will say, based on what we see now, that maybe we'll go with the 1.25 rotaburr, and because at least we can do dynaglide and move the burr across. So what I would suggest, this is not a simple case. It may take another half hour. If it's okay with you, and we are exactly at 12:58, 59 time, that we can break for lunch.
Okay.
At 1:45 you come, and this case will be shown on the side screen.
Yeah,
those who are interested, want to see, will continue to see this. This case will be done live, but not necessarily everybody has to be there. You can break for your lunch.
No, this is fantastic, but this is a tough case. I do want to hear what the panel thinks. I know you have a plan.
Take the opinion and
let's
the panel
talk about that a little bit about the panel.
I tell you, there's one good teaching point that if you can't wire because of guide support, you probably should try a different guide. And it looks like you should try to come from below. The ARTs are good here, or an Amplat's left left.
Or the AL 0.75.
Yeah, to try to get support in the cusp, because no matter what you do with these extenders, if you don't have guide support, the whole thing tends to back up on you.
Well, it sounds like the stent, in the
exactly. There is
RCA
stent
is
outside,
sticking
yeah.
out. I mean, it doesn't. That's the reason why they went with the Arma guide. It looks like. But that's a
Yeah, but
good
you should
good
you should
point.
still be able to size that up and get it if you're getting to the right plant.
Okay.
Yeah, other guide would be, I would say, will be the no torque.
no torque?
Yeah, and
Okay.
or 3DRC.
That's again notorious for not having back support,
Yep,
though.
big trouble with the support.
Support.
But with more support, the risk also is to damage the part of the stent which is inside the aorta. So it's very complex procedure when you have no support because of stent outside, and that's make our life complicated.
Stefan, how would you
cross
approach
with
a
the
case
wire
like this?
outside the
Stefan?
stent.
Yeah, great.
Well, I think you need time and patience. I think the first thing is the cannulation. First of all, this is not a radial case. I think you need to do it from femoral to have all the time and material available. I probably also would use an EMA or a JF4 catheter to first cannulate the lesion with a wire, and maybe then to exchange it over a fine cross catheter with a stiff wire, and then you can think whether you can externalize, take out this guiding catheter and exchange it against something with more support. But I think it's a little bit trial and error.
Yeah, difficult one. John, any other pointers? I think everyone is
trying to get
struggling with the guide.
Trying to get coaxial with the guide is sometimes trial and error with these because they, when they're protruding out a millimeter or two. There's a specialty guide that we use for high anterior rights that might work in this where the stent is sticking out. It's called a Medtronic 3D right catheter. It has a curve to it, then it points at it. It doesn't provide great backup and support. Will be coaxial. Should allow you to get a wire down. And I would probably use something, as I said, a little bit more sturdier than a fine cross catheter to get down and support your wire. Again, I've gone more to a Turnpike LP recently. Just because it's got a good profile, good push, and should allow you to get down to the lesion. And I agree wholeheartedly with trying to use that kind of a strategy again to get something more supportive into the distal to the lesion.
Well, this is going to be a very interesting case to watch over lunchtime on the side view.
All right.
Dr. Sharma, we're going to do that. And thank you so much. Incredible, 7 cases already this morning. 7 more to go this afternoon. Thank you so much. We're going to go for lunch. We have you on the side panel, and we'll see what you're going to come up with. Thank you. Everybody back here precisely at 1:45.
Sometimes I've been able to cannulate with the diagnostic catheter.
Right?
Yeah, I'm sure he's going to try
and
that
then
too.
probably exchange to a guiding catheter.
That
Excellent.
will be
Good.
the one thing we were just talking, because the bigger hook on our diagnostic catheter, we might help in this particular case, absolutely. All right.
Excellent. Thank you. 1:45, everyone. Not a minute late.